Hello again. Our topic of discussion in these slides is going to be urge urinary incontinence. And this is part of 4 lectures that I'm doing on urinary incontinence, really talking about the 4 major causes of what we call urinary incontinence or involuntary loss of urine. So we'll start out with a 65-year-old woman presenting to the clinic complaining of increased urinary urgency over the past 2 months. She's otherwise been in excellent health and is recently retired from her job as a high school health teacher. She is G3P2 with 2 uncomplicated spontaneous vaginal deliveries and 1 miscarriage at approximately 10 weeks gestation. She says that she uses the toilet to urinate about 15 times per day, and this has interfered with her activities as she is now unable to attend the movie theater with her husband or watch her grandson's hockey games without interruption to use the toilet. 2 days ago, she was unable to make it to the bathroom and lost a large amount of urine, which prompted her to come in. She denies any pain on urination or blood in the urine. Physical exam reveals a distraught but healthy appearing elderly woman. All vital signs are within normal limits. Heart rate is normal. A normal rhythm, lungs are clear, abdomen soft, non-tender, non-distended, grossly intact neurologically. Vaginal exam reveals mild hypopigmentation and dryness of the labia, but otherwise unremarkable. Bimanual exam reveals no masses. Q-tip test reveals 15 degrees of elevation. So you probably already know what this is, partially because this is a lecture on urge urinary incontinence, but just humor me here and think about what you would want to do next in this patient before you send her off with medication, which we will probably wind up doing. Before you send her home to do a voiding diary, what do you want to do for this patient before she leaves? You want to get a urinalysis. And a urinalysis is something that you will do for every patient who presents with a new complaint of urinary incontinence. And it is also something you're going to do for every woman who presents with, or maybe even every man too, who presents with complaints of increased urinary urgency. And what is urinary urgency? Urinary urgency is the need to go, or the perceived need to go to the bathroom more frequently than normal. And normal, for our purposes, is going to be, the cutoff is going to be 8 times per day. Okay, so you're up, let's say, 16 hours a day. If you're having to go to the bathroom, go to urinate more than once every 2 hours throughout the day, that's 8 times per day, that's going to be considered increased urinary urgency. This is a very difficult, it's difficult to make this definition at a certain number of times per day, because let's say you're drinking more water than normal, or you're drinking caffeine for one reason or another, you're probably going to be going more. If I'm drinking 4 or 5 cups of coffee per day and I'm drinking a normal amount of water, I'm probably going to be going to the bathroom much more frequently than I would if I were otherwise not drinking as much water or as much coffee. Okay, so to put that cutoff at 8 times per day, that's just the average person who's really not drinking any caffeine, not more than 1 or 2 cups of coffee, not drinking an excess amount of water. Okay, so that's just for normal people, but you want to get an idea. How much water are you drinking? Are you drinking more water now? Are you drinking caffeine, more caffeine than before? You want to get this in context. All right, so that being said, she has increased urgency. She's going more than around 15 times per day. That's almost twice as frequent as the average person at the upper limit. What you also want to know, and we didn't include it here in this vignette, but what you also want to know is when you do go to the bathroom to urinate, how much are you urinating? The average person feels the urge to urinate around 400 to 500 mils of bladder volume. So generally, a patient, when they urinate, will urinate about that amount or maybe a little less. So at least about 300 mils of urine. These women who have urge urinary incontinence, they will be urinating a lot less because they get the urge to go at a much smaller volume. So if you ask her, how much do you urinate? It's probably not going to be that much. She'll go frequently, but it won't be a whole lot of urine. And this is why they often refer to urge urinary incontinence as a small bladder syndrome. it's really not a good description of it, but the fact is that they go more frequently and it's a smaller amount of urine. So this is an elderly woman. Elderly women have a tendency to develop incontinence more than other segments of the population. Older women are more likely to develop stress urinary incontinence. They're more likely to develop urge urinary incontinence. And these two, stress and urge urinary incontinence, are the most common urinary incontinences. Urge urinary incontinence would probably be the second most, next to stress urinary incontinence. Another thing is that this affects patients' quality of life. So think about it. We take a lot of things for granted. You go out in public, we can control our bladder. You can go out and watch a movie and not feel like you go to the movie theater and not feel like you need to know where the bathroom is because you can make it. Okay, even if you really have to go, you can typically make it until you get home. These women, it's not the case. Even if they're not drinking any water, even if they go to the bathroom before they leave the house, they can almost rest assured that they're going to need to use the bathroom at some point while they're away. Think about it. You're going 15 times a day. That means you're going twice every 2 hours, right around that. Okay, so that means if you're going once an hour, it's almost certain that you're going to have to go when you get out in public. So for these patients, because they have that need to go and they may not have access to a restroom, a lot of times they will withdraw themselves from their daily activities, such as going to the movie theater where you do want to sit down for a couple hours and watch the movies, going to a hockey game where you're probably going to be sitting there for a couple hours and maybe not have access to a restroom. These are things that they would otherwise want to do, and so this can really impact their quality of life. Not to mention the fact that this woman has already been incontinent once, and that's going to be embarrassing if that happens in public. So it really does impact their quality of life. And do remember that urinary incontinence is one of the more common reasons that patients wind up having to go into nursing home. And so it's just really a big quality of life issue. Okay, so we have this woman who comes in. The first thing we want to do is get a urinalysis. Why? Because there is a certain type of urinary incontinence known as sensory irritative incontinence that presents very, very similarly to urge urinary incontinence. The difference is with sensory irritative incontinence, there is something going on in the bladder that is causing this increased urgency. So they will both urge urinary incontinence and sensory irritative incontinence, they will both present with increased urgency. The difference is there is some kind of bladder pathology going on with sensory irritative incontinence that's causing the detrusor muscle to become overactive. And so a lot of times they'll call sensory irritative incontinence hyperactive detrusor, but that's not really a great description because patients with urge urinary incontinence often have detrusor hyperactivity as well. So this is why we get a urinalysis, because some of the causes of sensory irritative incontinence include things like urinary tract infection. Very, very, very common cause of increased urinary urgency. Can also include things that are more malignant, for lack of a better word, like a bladder tumor. It can include things like foreign body. It can include, things like stones in the bladder. These all can irritate the detrusor. So this is why we get a urinalysis. And the urinalysis was unremarkable, meaning we can probably exclude a urinary tract infection or any other cause of sensory irritative urinary incontinence. So this is probably just regular old urge urinary incontinence. Okay, so we're going to go over basic anatomy, history and symptoms, which we already sort of talked about, how we go about diagnosing this, what are some of the causes behind urge urinary incontinence, and then how do we manage this. So this is urge urinary incontinence here in comparison to our other forms of urinary incontinence. What's going to set urge urinary incontinence apart from these other causes is the fact that these patients have increased frequency and urgency. And when they do go to the bathroom, it's not going to be quite as much. Now, remember, stress urinary incontinence, these patients don't have any problem unless they're coughing or sneezing or lifting something. With urge urinary incontinence, they don't have problems with that so much. They're just having to go very frequently throughout the day, and if they can't go to the bathroom when they need to, they're going to have an accident. And when they do have an accident, it's going to be the contents of their bladder. So it's going to be a large amount. Whereas with stress urinary incontinence, they're losing a small amount intermittently with those Valsalva activities. Now with urge urinary incontinence, they are going to have symptoms at night. So they will often wake up to go to the bathroom. Stress urinary incontinence, you don't see that. Now with overflow urinary incontinence, where there's often some kind of neurologic cause, usually this is what we know as a neurogenic bladder, and with bypass urinary incontinence, where there's usually a fistula between the ureter and the vagina, or between the bladder and the vagina, they will have nocturnal symptoms, but they won't be waking up to go to the bathroom. What's going to happen with these patients is that they're just going to leak. But these patients with urge urinary incontinence, they're going to be waking up with the urge to urinate. The urinalysis can vary with urge urinary incontinence, and here what I am doing is I'm including sensory irritative incontinence with urge urinary incontinence because the two often present identically. The difference is the urinalysis is going to show you some kind of bladder pathology with the sensory irritative urinary incontinence. With pure old urge urinary incontinence, the urinalysis will be normal as it was in this patient. The Q-tip test will be normal. However, important to remember, we're going to touch on this a few times as we talk about urge, that a lot of patients will have combination of stress and urge urinary incontinence. If you do urodynamics, what you will note, and this is really what's behind urge urinary incontinence, is that they have involuntary detrusor contractions even with small amounts of urine in their bladder. So here is our bladder. Here, the detrusor muscle is seen right here. The detrusor muscle is smooth muscle, and it is innervated both by the sympathetic and parasympathetic nervous system. It gets its sympathetic innervation by the hypogastric nerve, which comes from nerve roots T10 through L2. Gets its parasympathetic innervation from the pelvic splanchnic nerves, which come off of S2 through S4. And that is what causes the detrusor to contract and hence release urine. So you may have heard me refer to this term overactive bladder. There is a difference between urge urinary incontinence and overactive bladder. Overactive bladder is a common term that's thrown out amongst medical laity, and a lot of times it's referring to urge urinary incontinence. But these two aren't exactly the same. There is some overlap, but they're not exactly the same. So urge urinary incontinence is the involuntary leakage of urine, incontinence of urine, accompanied by or immediately preceded by a perceived strong imminent need to void. So they feel like they got to go, and if they don't go, they happen to lose urine. That's urge urinary incontinence. With overactive bladder, they have that urgency, that need to go, but they don't necessarily have incontinence. So they're just having to go more frequently. They're not necessarily incontinent. Now, that having been said, you can have overactive bladder. Often you do have overactive bladder and have urge urinary incontinence because you're incontinent of that urine. However, not all patients with overactive bladder are going to have urge urinary incontinence. You could just feel the need to go more often, but you can still make it and you're not actually incontinent. Okay, so patients with urge urinary incontinence, they have overactive bladder, but not all patients with overactive bladder are necessarily incontinent. There has been a study out called the NOBLE study, or National Overactive Bladder Evaluation Study, NOBLE, which took 5,204 adults, equally separated amongst sex, and it's basically a cross-section, getting all race groups, age groups, and it actually found that 16.5% met the criteria for overactive bladder. Now, that doesn't necessarily mean that they are incontinent, but they did find that these patients were going more frequently than what is considered normal, and that cutoff is probably 8 times per day. That number went up to 20% in patients over the age of 70 and over 30% in patients over the age of 75. For overactive bladder, the sex ratio was found to be equal, but women were more likely than men to be incontinent. And then this was interesting too. There is a direct correlation to BMI. So bigger women are more likely to develop urge urinary incontinence than smaller women. And that also holds true for stress urinary incontinence as well. So these are some of our medical causes of urinary incontinence. Now, when you look at a patient with urinary incontinence, they're just losing urine, we don't necessarily know the cause. However, we do know that there are some medical conditions that increase your risk of losing urine involuntarily. The first is kind of more complicated, and that would include things like dementia, delirium, or physical handicaps. So these patients really aren't incontinent of urine because of any kind of urinary tract pathology or stress urinary incontinence, urge urinary incontinence, overflow, bypass. The problem for these patients is that they're physically or mentally not able to get to the restroom when they need to, and so they lose urine. That's just what's called functional urinary incontinence. If it weren't for their dementia, delirium, their altered mental status, or their physical handicaps, if they were physically able or mentally able to get to the restroom, they would have no problem. It's this inhibition, this inability to get to the restroom that's leading to their problems. That's functional urinary incontinence. Okay, infection, that causes what looks like urge urinary incontinence. That's one of our causes of sensory irritative incontinence. Atrophic vaginitis is commonly associated with stress urinary incontinence. That suggests a low estrogen state. Psychological causes, kind of going back to the dementia, delirium, etc. But also, let's say you get really scared, you can lose urine in that regard too. Pharmacologic causes, this also includes not only drugs, but things like alcohol and caffeine. That can cause urinary incontinence. What you want to do, and make sure you're doing, is looking at the patient's medical list or their drug list and seeing if any of these things are there. In particular, you want to look for things like alpha blockers, and you also want to look for diuretics. Obviously, if you're on a diuretic, you're going to be more likely to be incontinent because you're creating more urine. Endocrine causes, diabetes mellitus, they're going to be going more because if it's not controlled properly, they're going to be creating more urine. Hypothyroidism, also restricted mobility, kind of going back to those inhibitive handicaps, and then stool impaction. This can do it in two different ways. First, you can get the, if there's impacted stool in the colon, that can push up against the bladder and cause an irritation of the detrusor muscle. You can also get a physical impaction of the urethra, and that can cause a urinary incontinence as well. So we'll talk about that here. Okay, so history. What do these patients come in telling you about? Generally, they're going to tell you. If they have urge urinary incontinence, they're going to tell you, I'm going to the bathroom more frequently than normal. And it's generally enough to interfere with their daily activities. So if they're only needing to go 7 or 8 times a day, which would be considered sort of the upper limit of normal, typically that's not going to cause problems with their daily activities. But if they're going 15, 16, 17 times a day, definitely that's going to be causing problems because they're going frequently enough to where they're not able to go 40 or 50 minutes without needing to use the restroom, knowing where the restroom is. And this really causes a problem, not so much at home, but in public. Okay, so imagine last time you went somewhere in public. You probably spent 2 or 3 hours out of the house. If it were this woman that we talked about who's going 15 times a day, she would have needed to use the restroom twice in that period of time at the threat of becoming incontinent. So you can see how this would really interfere with their daily activities. Now, when patients with urge urinary incontinence are incontinent, it's going to be a large amount during an episode. They lose the contents of their bladder. And even though their bladder does not quite hold as much because of the detrusor hyperactivity, they still lose a lot. So compare this to stress urinary incontinence. With stress urinary incontinence, they may sneeze and lose 20 mils of urine. Not a ton. Still enough to be problematic, but not a ton. With urge urinary incontinence, if they don't get to the restroom when they need to, they will spill out the contents of their bladder. And that can be 200, 300 mils of urine, which, I mean, if you think about it, take 200 or 300 mils of water and pour it on your crotch. You can see how that is a lot, and that's going to cause some major problems. Okay, so unlike in stress urinary incontinence, when their bladder is empty, patients with urge urinary incontinence will not lose urine on coughing and sneezing. But important to remember that mixed incontinence is very, very common. So you may put a patient on medication, a patient with urge urinary incontinence on medication, but they'll still have symptoms when coughing and sneezing. So they could have stress urinary incontinence as well. And it makes sense that these two often come together because it's the same patient population, elderly or postmenopausal women that are at increased risk for both. So keep an eye out for features of both in the same patient. It's not uncommon. Also, common thing for urge patients to complain about is that they're waking up to urinate. A history of bladder surgery is important. If they have had bladder surgery in the past, that can suggest possible urethral compression, and that can result in detrusor instability. Detrusor instability or detrusor hyperreactivity is not your diagnosis that you can make clinically. That we would consider overactive bladder or urge urinary incontinence. Detrusor instability is something that needs to be diagnosed urometrically. As far as symptoms, make sure to rule out urinary tract infection. So ask the patient, does it hurt to urinate? Is there any blood in your urine? What color is your urine? And then also rule out any urinary tract pathology. And this is done by getting a urinalysis. This is a reason that we get the urinalysis. Because irritative urinary incontinence, sensory irritative urinary incontinence, presents almost identically to urge urinary incontinence as far as the history goes, with the exception that if it was a UTI, they may complain of pain while they urinate. Physical exam is mostly unremarkable, so their genitalia should be normal. There may be some degree of atrophy since this tends to happen in elderly women. You shouldn't notice any vaginal diverticula. Their neurologic examination should be normal, but there are some exceptions to that, and I want to talk about that briefly in a little bit. But for the vast majority of patients, it's going to be normal neurologic reflex. Ask the patient to strain while doing vaginal exam because that can help you see any symptoms possibly of mixed incontinence. It might not necessarily be diagnostic, but if a patient empties her bladder and she's still losing urine when she strains, that points you towards a stress urinary incontinence. Another thing that might point you towards stress urinary incontinence is the Q-tip test. So remember the Q-tip test, we place that gelled cotton tip applicator into the urethra up to the junction with the bladder, and then you look for the elevation above the horizontal plane. And if it's more than 30 degrees, that suggests that there's urethral hypermobility, and that's consistent with with a stress urinary incontinence rather. Q-tip test should be negative if it's pure urge urinary incontinence. But again, you can have features of both. You can have a mixed stress urge urinary incontinence, and in that case, your Q-tip test would typically be positive. Urodynamic studies are not indicated as part of your first-line diagnostic testing. What you really want to make sure you're getting is a urinalysis. But if you suspect a neurologic etiology, then it may be useful to get a urodynamic studies. Now, if you do urodynamic studies, what you would find in pure urge urinary incontinence, you would find involuntary detrusor contractions despite a low urinary volume in the bladder. And that's really what's behind that urge to urinate, is that they're getting those detrusor contractions, and it's making them feel like they need to go despite having just a small amount of urine in the bladder. What are the causes of urge urinary incontinence? Most of them are idiopathic. However, some patients will have neuromuscular etiologies. So these can be things like spinal cord injuries, stroke, multiple sclerosis, dementia, diabetes, peripheral and autonomic neuropathies, cauda equina lesions. If you think about it, if you think of overflow incontinence, which is also often neurologic in etiology. There's some of the same causes. So if you have disturbances of your of these nerves down there, that can lead to either an overstimulation of the detrusor, which would lead to urge urinary incontinence, or it can lead to an understimulation or hypoactivity of the detrusor, which would cause your overflow incontinence. So you can either have it where your detrusor muscle is hyperactive, not acting as it should, or where you cannot contract your detrusor muscle, which also is not acting as it should. If it's the latter, that's going to lead to the overflow incontinence, where you're unable to voluntarily urinate, and so your bladder gets so full that you begin to dribble out urine. So neuromuscularly, you can have some of the same causes behind both. And certainly if you have neuromuscular issues, that can impact your bulbocavernosus reflex. Iatrogenic urge urinary incontinence can be due to a bladder neck procedure. If it's too tight, you can get urethral obstruction and compression that can lead to detrusor instability. Irritation, we talk about sensory irritative urinary incontinence. That can be things like UTI, bladder stones, bladder cancer, foreign bodies. This should be differentiated out with a positive urinalysis. Either you're finding white blood cells and nitrates on with the UTI, or you're finding red blood cells with bladder stones, bladder cancer, and foreign bodies. And then there are various drugs that can be behind this as well. Now, the way we manage urge urinary incontinence in comparison to stress urinary incontinence, they're quite different. So with stress urinary incontinence, we really emphasize conservative management. So things like Kegel exercises, improve bladder habits, going more frequently throughout the day. That doesn't work so well in urge urinary incontinence because the problem is not with their pelvic floor muscles. It's certainly not that they're not going enough every day. The problem is that detrusor muscle being hyperactive. And so there's really not a lot of conservative management we can do for these patients. You can only strengthen the pelvic floor muscle so much, and that might help to some degree, but typically it's not going to be to a significant amount of a degree to where you're really improving the quality of life for these patients. So we tend to go to pharmacologic therapy, and that is good that we can do that because remember, in stress urinary incontinence, there's really not a whole lot of drugs that are useful for stress urinary incontinence. So with stress, it tends to be conservative management and then surgery. With urge urinary incontinence, there are pharmacologic therapies that we can use. And in fact, we do use these in many patients with urge urinary incontinence. So the cornerstone of pharmacologic therapy for urge urinary incontinence, I would really even venture to say the cornerstone of therapy in general, is going to be anticholinergic drugs. And these include drugs such as tolterodine or Detrol, fesitaridine, and oxybutynin. These are all anticholinergics. They all inhibit that muscarinic receptor that is responsible for contracting the detrusor muscle and ultimately urinating. And so by blocking these, what you do is you decrease the pressure in the bladder. So these drugs, not only are they anticholinergic, but they also have some muscle relaxant properties as well. The adverse effects of these drugs is that, of course, they're anticholinergic. So they can, because they're anticholinergic, they can lead to constipation and things of that nature. For the most part, you don't get a whole lot of side effects from these, especially tolterodine, which tends to be the preferred drug. And the reason you don't get that much side effects is because these are quite targeted at the specific muscarinic receptors that predominate on the bladder. But good to know, because these are anticholinergic drugs, to look out for anticholinergic toxicity. Mirabegron is a beta-3 adrenergic agonist, and so this relaxes the dome of the bladder. Remember, those beta receptors predominate on the dome, and by activating those beta receptors, you will relax the smooth muscle. Remember that you have beta receptors in the smooth muscle of your bronchi, and you give a beta agonist like albuterol, you relax that smooth muscle and you can breathe better. Same with the smooth muscle on the bladder. You give a beta agonist, you relax the smooth muscle of the bladder, and you can fill your bladder with urine better. And that is what mirabegron is, or mirabetrip. You see that one on TV a lot. Tricyclic antidepressants, imipramine. This is not commonly given. However, if you have a patient with combination urge and stress urinary incontinence, this can be useful. These tricyclic antidepressants also have the effect of increasing the intraurethral pressure, and that can be useful for stress urinary incontinence as well. So if a patient has combination urge and stress urinary incontinence, giving the patient imipramine can be preferable, or at least useful. And then topical estrogen, again, this can be useful for patients who also have stress urinary incontinence, because these patients also tend to be hypoestrogenic, if that's a word. But this is something you can give to them. It can also help with some of their symptoms of atrophic vaginitis, which can include vaginal dryness and dyspareunia. So that's another way that you can go as well. And they make that in a cream, so you're not taking that orally or anything. All right. So if you're asked on the USMLE, what's the pharmacologic management, or what's the best first step in therapy for a patient with urge urinary incontinence? Definitely go with the anticholinergics. So this is mirabetrip, beta-3 agonist. And there are a lot of ads out there for this, but it usually includes this little cartoon bladder. So this is like urge urinary incontinence. She's in the line at the grocery store, and her bladder is telling her, you need to go right now. Okay, so we talked about urge urinary incontinence. The urodynamics, I wouldn't stress out too much about knowing all these urodynamics, but it is good to know exactly what's behind this pathophysiologically. So USMLE might throw that at you. What you would see in urge urinary incontinence is involuntary detrusor contraction, particularly at a low urinary volume. Urge urinary incontinence is distinguished by increased frequency and urgency. When they lose urine, it's going to be a large amount, and they will have symptoms at night. But those symptoms at night are going to be awakening to urinate. Whereas with stress urinary incontinence, there's no nocturnal symptoms whatsoever. They don't lose urine. They don't need to wake up to go to the bathroom. Whereas with overflow and bypass urinary incontinence, yes, they do lose urine at night, but they're not waking up to go because they're just dribbling out urine. But these patients will have to wake up to urinate, usually more than twice a night. All right, so hopefully you got the idea of what to do here. Oh, and then also remember, this probably goes without saying, but if you do have a patient with sensory irritative incontinence, in other words, they have a positive UTI, then if you suspect urinary tract infection, treat the underlying cause. If you suspect anything else, like a bladder tumor, a foreign body, then you need to do cystoscopy. And typically the way that that's going to wind up presenting is that they're going to have frequent abnormal urinalyses and frequent bouts of uncontrolled urge urinary incontinence that are refractive to therapy. So in that case, you may need to go further and do cystoscopy. But if it's just UTI, just treat it with an antibiotic, and you'll be fine. Okay, so any questions, go ahead and write me a note below. I'll see you next time.